İbrahim salona girişinde anısal bir değeri olduğunu söylediği için recording'i başlattım sevgili hocalarım. Birazdan dalya diyeceğiz. O kadar bir insan var. 5 kişi daha gelince. Evet, 100 olduk. Süratle geçtik.
Hocam, evet. Siz isterseniz kongreyi başlatın. Ben konukları içeriye alabilirim.
Tamam Arif Hocam. Diyorsun ki bu Zoom olduğu için akademik bekleme süresini beklememize gerek yok diyorsun. Bir 5 dakika beklese miydik acaba diye düşündüm ben de. Bir isterseniz bir 2-3 dakika daha bekleyelim. Ondan sonra da başlayalım.
Hocam yeniden hatırlatma yapabiliriz. Bazı konuklarımız Rumuz kullanıyor.
Evet, söyleyeyim ben onu. Bu arada Oscar da geldi Arif Hocam. Sevgili hocalarım, Rumuz yazmayalım lütfen ya da iPhone'la girdinizse iPhone diye yazıyor. Lütfen açık adları yazalım. Çünkü bu şeylerin özetlerini aldığımız zaman Zoom'da hepinizin açık adını görebileceğiz ve bu katılım belgesi düzenlemede çok büyük bir kolaylık olacak. Onun için lütfen açık isim ve soyadlarımızı yazalım. Çok kolay değiştiriliyor. Hemen ekranda şeyinizin yanına geldiğinizde şu 3 noktaya tıkladığınızda rename dediğinizde çok kolaylıkla adınızı değiştirebiliyorsunuz. Cep telefonlarında biraz daha zor oluyor ama kolayca yapabilirsiniz. Nilufer başlayalım mı yavaş yavaş? Senin için uygunsa. Tamam. Peki. Evet sevgili değerli katılımcılar, sevgili hocalarım, değerli meslektaşlarım, hepiniz TEGED'in 11. Ulusal Tıp Eğitimi Kongresi'ne hoş geldiniz. Tabii bu kongre çevrim içi bir kongre, onun için de çok farklı şartlarda bir aradayız ama umarım hepinizin katkısıyla, katılımıyla güzel bir kongre olacak. Ben açılış konuşmalarına geçmeden önce hani en başta denilir ya, İşte cep telefonlarınızı kapalı tutun, fuayeden çay kahve içebilirsiniz falan gibi duyurularımız olurdu ya eskiden. O duyuruları yapamayacağız ama sizler için birkaç tane duyurum var. Onun için hani onları söyleyip ondan sonra açılış konuşmalarına geçeceğiz. Şimdi bu kongre ilk çevrim içi kongremiz ve hepimiz için farklı bir deneyim olacak. Karma eğitimin, online eğitimin, işte uzaktan eğitimin, bunların iç içe geçmiş olan kavramlarının tartışıldığı, başladığı, sürdürüldüğü bu günlerde biz de böyle bir platformdayız hep birlikte. Ve biz az önce dediğim gibi böyle atraksiyonlu, konserli, işte sergili, hoş bir açılış sizin için planlıyorduk. Hatta süreç içinde de Acıbadem olarak biliyorsunuz bu kongreyi TEGED'le birlikte Acıbadem ev sahipliğinde yapıyoruz. O yüzden hoş şeyler planlamıştık ama maalesef yüz yüze karşılaşamıyoruz. Yine de elimizden geleni yaptık. Program oldukça dolu bir program. Çok sevgili hocalarımız, yurt dışından konuklarımız var. O yüzden de dolu dolu geçeceğini, sözlü bildiri oturumları, kurslar ve çalıştaylarla dolu dolu geçeceğini düşünüyoruz. 3 gün öğleden sonra bir aradayız. Yine 2 tane tanıtım konuşmamız olacak. Onları da takip ederseniz seviniriz. Elsevier'in online kaynak kullanımıyla ilgili bir tanıtımı ve sınav otomasyon sisteminin bir tanıtımı var. Onun için onları da programdan takip etmenizi umuyoruz. Bu 3 günlük süreç içinde birkaç tane önemli hatırlatma. Şu anda zaten hepiniz çok rahatlıkla girdiğinizi görüyoruz. Sadece programdaki oturuma katıl linkine tıklamanız yeterli oluyor bugün de az önce deneyimlediğiniz gibi. Kongre boyunca sorular sesli olarak alınmayacak. Katkılar da o yüzden yani söz hakkı verilmeyecek ne yazık ki. Ama bu söz hakkınız yok demek değil. Hepinizi chatten takip ediyor olacağız. Onun için ister sorunuz olsun, ister o konuyla ilgili bir katkı koymak isteyin. Lütfen chat'e yazın. Bu konuda hiçbir sınırlama yok. Hem Oturum Başkanı hem de bizler yönetim kurulu olarak bu konuyu takip ediyor olacağız ve bütün soruların ve bütün katkıların ortamda, tartışma ortamında paylaşılmasını sağlamaya çalışacağız. Oturumların süreleri konusunda kısıtımız var çünkü Zoom'a girmek, çıkmak ve her oturumu tekrardan açmak durumundayız. O yüzden oturumlar 10 ila 15 dakika uzama marjı var en fazla. Bu sırada biz oturum başkanından rica edeceğiz ve oturumu kapatacağız. Ama sorulmamış sorularınız veya eksikleriniz olursa lütfen çekinmeyin. Bize yine utek@acıbadem.edu.tr adresinden yazın. Bunların da karşılıklı paylaşılmasını sağlamaya çalışacağız. Katılım belgesi için soranlar oluyor. Buna da bir açıklık getirelim. Katılım belgesi için kongreye kayıt olmuş kişilere katılım belgesi verilecek ve ana oturumların en az %70'ine katılım şartı aranacak. Bunu web sayfasında da duyuru olarak verdik ve bu konuda da o yüzden işte adınızı, soyadınızı yazmanız önemli. Zoom meetinglerine katılanların raporlarını aldığımızda o isimlerle kayıt listesini bir araya koyup sertifikalarınızı hazır edeceğiz. E-posta ile kongre sonrası hazır olduklarında size bilgi göndereceğiz. Yine web sayfasına girip kolaylıkla oradan belgenizi indirebileceksiniz. Evet, şu noktada ben yine son olarak cep telefonlarınızı kapatın şeyi yapardım normalde ama bugün size sadece kameralarınız açık, chatten sorularınızı sorarak ve katkılarınızı koyarak kongreye katılım sağlayın diyorum sadece. Hepinize iyi bir çevrim içi kongre diliyorum ve şu andan itibaren de sözlü açılış konuşmalarını yapmak üzere sırasıyla TEGED Başkanı Doc.Dr. Nilufer Demiral Yılmaz'a ve bize ev sahipliği yapan Acıbadem Üniversitesi Tıp Fakültesi Dekanı Prof.Dr. Yasemin Alanay'a bırakıyorum. Çok teşekkürler, iyi kongreler. Sevgili Nilufer, söz sende. Sesin kapalı. Hala kapalı. Şimdi açabilirsin yanılmıyorsam. Evet.
Teşekkürler Melike. Değerli konuklar, saygıdeğer hocalarım, meslektaşlarım ve sevgili öğrencilerimiz. Tıp Eğitimi Geliştirme Derneği olarak Acıbadem Üniversitesi Tıp Fakültesi ev sahipliğinde gerçekleştirdiğimiz 11. Ulusal Tıp Eğitimi Kongresi'ne hoş geldiniz. Kongremiz, ülkemizde tıp eğitimi alanında önemli çalışmalar yürüten Türk Tıp Eğitimi Derneği ve Tıp Eğitimi Programlarını Değerlendirme ve Akreditasyon Derneği tarafından desteklenmektedir. Yapmış oldukları katkılar ülkemiz tıp eğitimi için çok değerlidir. Dostane ilişki ve sıkı işbirliğiniz için teşekkür ederim. Tıp eğitiminin olmazsa olmazı öğrencilerimiz. Kongremize göstermiş olduğunuz yoğun ilgi ve katılımınız bizi güçlendirmekte. İyi ki varsınız. Bugün hep beraber bir ilki yaşıyoruz. Nisan ayında İstanbul'da Acıbadem Üniversitesi Tıp Fakültesi'ne yapmayı planladığımız ve tüm hazırlıklarını tamamladığımız kongremizi pandemi nedeniyle Ekim ayında çevrim içi olarak gerçekleştiriyoruz. Kongremizin dijital platforma taşınması kararı derneğimiz açısından incelikle değerlendirilmesi gereken bir konuydu. Kongremiz bu yılda TÜBİTAK tarafından desteklenmişti ancak çevrim içi olması durumunda bu desteği kullanamayacaktık. Bu kararı almamızı kolaylaştıran, derneğimize herhangi bir maddi yük getirmeden kongremizin gerçekleşmesine katkı sunan Doktor Arif Onan, Doktor Barış Sezer, Doktor Ozan Karaca ve Doktor Yusuf Yılmaz karşılık beklemeden bizleri destekledikleri için çok teşekkür ederim. Kongremizde tıp eğitimi birçok alanında katkı sunacak, deneyimlerini paylaşacak olan çok değerli bilim insanları aramızda görmekten onur duyuyoruz. Ülkemizden çok sayıda değerli konuşmacının yanı sıra profesyonelizm konusundaki çalışmaları ile tanınan Doc.Dr. Traynor ve EPA konusunda önemli çalışmaları olan Dr.Dr. kongremizde sizlerle bilgi birikimlerini paylaşacaklar. Her biri birbirinden değerli tüm konuşmacı, oturum başkanı, kurs ve çalıştay yürütücüsü hocalarımıza ve öğrencilerimizle sizlerin huzurunda teşekkür etmek istiyorum. Kongremizde 6 kurs, 2'si öğrenci çalıştay olmak üzere 5 çalıştay, 2 konferans, 3 panel, forum ve öğrenci oturumları yer almaktadır. Ayrıca programda 5 öğrenci oturumda olmak üzere 33 sözlü bildiri, 68 poster bildiri sunulacaktır. Derneğimizin yayın organı olan ve özellikle son dönemde birçok ulusal ve uluslararası indekslerce tanınır hale gelen Tıp Eğitimi Dünyası dergisinde emeği geçen başta Dr. Sabri Kemahlı ve Dr. Erol Gürpınar olmak üzere editörler kurulunu başarılarından dolayı kutluyorum. Kongrenin düzenlenmesinde eşsiz bir uyum içinde çalıştığımız Başkan Yardımcımız Doktor Yeşim Şenol, Doktor Meral Demirören, Doktor Sevgi Turan ve Doktor Erol Gürpınar. Verdiğiniz yoğun emekler için her birinize ayrı ayrı teşekkür ediyorum. Titizlikle her ayrıntıyla ilgilenen Kongre Sekreterimiz Doktor Melike Şahiner, Doktor Levent Altıntaş ve teknik sorumlumuz Doktor Yusuf Yılmaz. Sizlere minnettarım. Ve son ve büyük teşekkürüm de Acıbadem Üniversitesi Tıp Fakültesi Dekanlığı'na ve Yerel Düzenleme Komitesi'ne. Kongremizin fakültenizde düzenlenmesini teklif ettiniz ve kapılarınızı bizlere açtınız. Katkılarınız için çok teşekkür ederim. Her yıl bir kez olmak üzere verilen Tıp Eğitim Geliştirme Derneği Araştırma Ödülünü kazanan araştırmacılar ve yayınları kongremizin son gününde ilan edilecek. Son olarak kongremizin tıp eğitimi alanına bilimsel katkı sunmasının dışında bu alana gönül veren tıp eğitim camiasının sosyal bağların güçlendirmesi gibi bir işlevi olduğunu düşünüyorum. Bu yıl yan yana olamasak da bu platformda da sıcaklığımızı hissedeceğiz. Bir sonraki yıl düzenlenecek sempozyumda umarım sağlıkla kavuşmanın sevincini yaşarız. Sözlerime son verirken kongremizin başarılı geçmesi dileğiyle saygılarımı sunuyorum. Teşekkür ederim.
Evet. Reaksiyonlar kullanabiliyoruz. Bu çok hoş oluyor. Hemen ekranın altında reaksiyonlardan böyle güzel el çırpabiliyoruz Yasemin'in konuşmasından önce. Evet Yasemin Hocam, söz sizde.
Çok değerli hocalarım, sevgili meslektaşlarım. Hepiniz hoş geldiniz. Fiziksel olarak bir arada olamamamız çok büyük talihsizlik ama dünyanın içinden geçtiği süreci düşünürsek yine de mevcut koşullara en iyi şekilde adapte olduğumuzu düşünüyorum. Ben başta Tıp Eğitimi Geliştirme Derneği'ne organizasyon sürecindeki yoğun emekleri nedeniyle teşekkür etmek isterim. Harikulade bir program. Bu toplantıların, yani bu kongrenin 11.si düzenlenirken özellikle bir klinisyen ve tıp eğiticisi olarak sizlere şimdiden bir kez daha geçmişteki ve bundan sonraki düzenlediğiniz toplantılar için teşekkür etmek istiyorum. Çünkü bizler özellikle klinisyen olarak eğitimin içerisinde yer alanlar bu toplantılardan sizin hedeflediğinizin çok çok ötesinde faydalanıyoruz. Ben kendi adıma çok yakın tıp eğitimcileriyle birlikte çalışma fırsatı bulduğum halde katıldığım her toplantıda hem eğitimin yönetimine dair hem de elde edilen tecrübelerden çok çok faydalandım. Öğrenci katılımının olması müthiş bir şey. Çünkü biz bu pandemi döneminde de gördük ki eğitim gerçekten bir ekip işi. Hele hele uzaktan yapıldığında bu ekibin bilgi akışını iki taraflı çok yoğun oluşturması gerekiyor. Teknoloji yetmiyor. Teknolojiyi nasıl kullandığınız önemli hale geliyor. Pandeminin getirdiği koşullar aslında belki de sizlerin senelerdir hayalini kurduğunuz bizler gibi tıp eğitiminin bilim olarak bize sunduklarını iyi kullanamayan, yeterince iyi kullanamayan eğiticileri eğitme fırsatı verdi sizlere. Bundan sonrası için de bu mecburi hızlandırmanın hem bizlere, eğitimin yönetimindekilere hem öğrencilere farklı bir eğitim ortamı sağlayacağını düşünüyorum ve belki de dünyanın her yerinde benzer süreçlerin yaşanıyor olması da büyük bir avantaj. Çünkü hemen hemen her ülkede, doğuda, batıda bir şekilde insanlar teknolojiyi kullanarak yeni çözümler üretiyorlar. Biz de kendi ülkemizde 100'ün üzerinde tıp fakültesi binlerce öğrenciyle elbette kurumlarımıza özgü çözümler üretirken yeni öğrenme, yani tıp eğitiminin 6 yıllık dönemini en iyi nasıl değerlendiriz'i yeniden düşünme fırsatına sahibiz. Bu alanda sizlerin bu kongre boyunca tartışacağınız her şeyin önümüzdeki yıllarda tıp eğitimi alanında çalışan, sahada görev alan klinisyenlere ve diğer eğiticilere çok faydası olacağını düşünüyorum. Acıbadem Tıp Fakültesi olarak sizleri keşke burada ağırlayabilseydik. İnşallah başka vesilelerle bir araya gelme imkanımız olur. Sizleri camia olarak çok çok seviyoruz. Yani şeffaflığınızı, paylaşımcılığınızı, birbiriyle olan ilişkilerinizi ben şahsen çok nasıl diyeyim, özenerek takip ediyorum. İskender Hoca başta olmak üzere bütün liderlik ekibiniz bilgiyi en alttakilerle en mütevazi şekilde paylaşma prensibini çok iyi uyguluyorsunuz. Böyle devam edin. Tekrar teşekkür ediyorum. Güzel bir kongre diliyorum. Ben de oturumların büyük çoğunluğuna katılmaya gayret edeceğim. Kayıtları da sonradan herhalde seyretme, izleme fırsatımız olacak kaçırdığımız oturumlar için. Çok güzel bir kongre diliyorum. Teşekkür ediyorum.
Çok teşekkürler sevgili Nilufer'e ve sevgili Yasemin'e bu konuşmaları ve katkılar için çok teşekkür ediyoruz. Şimdi aslında açılış konuşmasına 15 dakikamız var. Fakat Dr. Traynor bizimle birlikte. Onun için Sabri Hocam eğer sizin için uygunsa, Oscar için de uygunsa sizin tanıtımınız ve oturumun şeyiyle başlayalım isterseniz. Oscar'a tabii siz bir giriş yapmak isterseniz, yoksa ben mi davet edeyim, nasıl isterseniz hocam.
Davet edebiliriz Oscar'ı. Ben bir tanıtımını yapayım.
Tamam.
Teşekkür ediyorum bu açılış uğrunda bana bu görevi verdiğiniz için. İlk konuşmacı Doktor Oscar Traynor bir cerrah, hepatopankreatik biliyer cerrahide özellikle bir deneyimi var. Ama ondan daha onun da ötesinde cerrahi eğitiminde çok zaman geçirmiş. Halen Royal College of Surgeons Ireland'ın mezuniyet sonrası cerrahi eğitim dekanlığını ve cerrahi eğitimi mezuniyet sonrası profesörlüğünü yürütüyor. Cerrahi eğitimi ve simülasyon eğitiminde, özellikle cerrahi simülasyonda çok çalışmaları var. Cerrahi pratiğinden ayrılmış birkaç sene önce. Fakat hala yine Dublin'de çalışmalarını sürdürüyor. Hasta güvenliği konusunda çalışmaları var. Ve aynı zamanda i360 Medical adındaki bir tıbbi cihaz inovasyon şirketinin de kurucularından kendisi. Tek bir konuşma için davet edilmişti. Professionalism in 21st Century Medical Practice adı altında. Fakat kendisi sürenin uzun olduğunu, 90 dakika ayrıldığını öğrenince ikinci bir konuşmayı da yapmak istediğini belirtti. Biz de bunu memnuniyetle kabul ettik. Birbiriyle bağlantılı. Birincisi profesyonellik, 21. yüzyıla profesyonellik. İkincisi de klinik ortamda saygısızca davranışlar konusunda iki konuşması olacak. Dr. Traynor, I would like to welcome you to give your talk. I have introduced you to my colleagues, briefly summarized your CV, and I would like to announce you to give your first talk on professionalism in 21st century medical practice. Dr. Traynor?
Dr. Traynor is in the meeting, but Arif Hocam.
Oh, he's here.
Yes. Arif Hocam, Dr. Traynor'a co-hostluk verdik mi?
Vermiştik. Çıktı herhalde. Yeniden bakıyorum.
Tekrardan lütfen. So, hello, Dr. Traynor.
Okay, can I share my screen, please?
Yes, we are giving in a minute.
I gave the permission.
Yes, okay, Dr. Traynor.
Okay. Can you see that clearly?
No, Dr. Traynor, we
Cannot
only...
see your screen.
Good.
Can you see now?
Yes, we can see.
You can see my PowerPoint?
Yes, we can see Dr. Traynor.
Okay.
Perfect.
Chairman, ladies and gentlemen, good afternoon. I'm very honored to have an opportunity to present here today at UTech 20 on the very important topic of professionalism in 21st century medical practice, and to share with you some of the initiatives which we have introduced in this area at the Royal College of Surgeons in Ireland. I'm really sorry that I cannot be present in the wonderful city of Istanbul, but hopefully in the not too distant future, we can all congregate together again for our major medical conferences. The online platforms such as Zoom have really helped us all to keep in contact over the past 7 months, but there is actually no substitute for that personal interaction with colleagues from around the world that happens at international conferences. I would like to start by sending you greetings from Dublin in the Republic of Ireland. Ireland is a small island nation, very close to, but quite separate from the United Kingdom. Ireland is situated on the very western extremity of Europe and lies almost 2,300 kilometers from Istanbul. Like most countries, we are currently still battling against COVID-19 pandemic, which has severely disrupted our health service and every aspect of our way of life. The Royal College of Surgeons in Ireland is situated in our capital city of Dublin. Our college was founded in 1784 and is responsible for all surgical training and surgical practice in Ireland. But we also run a very large undergraduate medical school and also undergraduate programs in physiotherapy and pharmacy. At postgraduate level, we run programs in nursing, radiology, dentistry, emergency medicine, sports and exercise medicine, and physician associate studies. RCSI is therefore officially designated as a University of Medicine and Health Sciences. My session today deals largely with the whole area of behaviours in healthcare. Good quality healthcare and safe healthcare is not just about what we know or what we are able to do. It is also about behaviour, how we interact with patients, with colleagues, and with society. In the first part of my session, I will talk about professionalism and what that means in the context of 21st century medical practice. Then, in the second part of my session, I will address more specifically the important issue of disrespectful behaviour in the clinical environment. Development of appropriate values, attitudes, and behaviours is a really important part of the professional development of all doctors. The collective embodiment of these values, attitudes, and behaviours is called professionalism, and it forms a key part of our contract with society. It is this implicit contract with society that actually makes us a profession and differentiates us from other occupations, careers, and trades. Put quite simply, professionalism is at the heart of being a good doctor. Unfortunately, professionalism is one of those things that attracts more attention when it is not present than when it is present. Over the past 15 years, many countries have had high-profile examples of poor professional behavior and performance by doctors. These cases have caused real harm to many patients, and I'm sorry to say that in many cases, patients have died unnecessarily. This has significantly eroded public confidence in our profession, and particularly public confidence in our ability to regulate our own affairs. As a result, there is a renewed confidence in a renewed focus on the importance of professionalism, and there has been much discussion about how we can teach and assess professionalism in our doctors of the future. But although professionalism is very topical right now, in fact, the concept of professionalism is not new at all. Indeed, professionalism dates back to the time of Hippocrates, who practiced on the tiny Greek island of Kos almost 2,500 years ago. Hippocrates is often referred to as the father of medicine. He practiced in the Asclepion of Kos, and it was he who first outlined the principles of professional behavior and performance. Principles which later became enshrined in the Hippocratic Oath. Now, if we consider for a moment how we actually teach professionalism to our current and future doctors. Professionalism has traditionally been part of the so-called hidden curriculum. By this I mean that it is not formally taught through didactic lectures and seminars. Instead, professionalism is learned by the example of our trainers and other senior doctors to whom we are exposed during training. Many medical specialties, particularly surgery, use a traditional apprenticeship model of training. There are two essential ingredients for the success of apprenticeship, namely the opportunity to engage in a large volume of repeated practice, and very importantly, the relationship with our trainer. This relationship functions as a role model effect. Trainees learn their professional values, behaviors, and attitudes by watching and emulating their senior colleagues. This role model effect has been very influential in the development of trainees in all specialties. But in fact, role models are important throughout life. From early childhood, parents act as role models for their children. Later, school teachers, sports coaches, and youth leaders are very important role models. But even in adult life, we all have people whose values, attitudes, and behaviors we admire and wish to emulate, whether they be sports stars, business entrepreneurs, politicians, or activists for social change. The fact is that role models are a very important influence on human behavior. And so too it is in medicine. Our senior medical colleagues act as role models for trainees and pass on their values and behaviors by example. But for a variety of reasons, the exposure of trainees to trainers and role models is significantly reduced today compared to even 10 or 15 years ago. The result of this is that we have a real challenge in how to inculcate professional values, attitudes, and behaviors in our doctors of tomorrow. At the Royal College of Surgeons in Ireland, we have developed an initiative to support the training of professionalism for our young surgeons and other doctors. This is an online course on professionalism in 21st century medical practice, and it has recently been launched and made available for all doctors working in Ireland. Our online course on professionalism was developed in collaboration with a commercial media development company and was designed to be engaging and stimulating, whilst at the same time covering an extensive syllabus on medical professionalism. The course is based on the Irish Medical Council's Guide to Professional Conduct and Ethics for Registered Medical Practitioners, which was published in 2016. There are 12 individual modules which are grouped into 3 broad areas of partnership, practice, and performance. The modules on partnership deal exclusively with relationships, relationships with patients, relationships with colleagues, and relationships with society. The modules on practice deal with ethical practice, maintaining health and fitness to practice, continuity of care, and patient safety. The modules on performance deal with professional performance, honesty and integrity, confidentiality, and teaching and mentoring. The course is specifically designed to be accessed on any mobile device and particularly on the smartphone. This means that doctors can access the course anytime, any place, and can do as much or as little of the course as suits their circumstances at any time. Within each of the 12 modules, there are a number of sub-modules or thematic areas. For example, the module on relationships with patients deals with aspects of the doctor-patient relationship, respect, the duty of advocacy, and aspects of trust between doctors and patients. Each one of the 12 modules has 4 component parts. Firstly, there is a 7 or 8 minute video which introduces the subject matter of that module. Course participants can then enter the learning resource area, where they will find a selection of scientific papers and videos which have been handpicked for their relevance to the subject matter of that module. On completion of the reading and viewing material, participants can take an MCQ test. And finally, if they pass the multiple choice question test, they can download and print their CPD or Continuing Professional Development Certificate. I'm now going to show you 2 examples of the module videos to give you a sense of the content and the mode of delivery of the subject matter. The first video is taken from Module 1 and deals with the whole area of compassion and empathy.
Patients are fellow human beings who are sick, unwell, or possibly even at risk of dying, and they want to be cured. They come to us as doctors in the hope that we can make them better, or maybe even save their lives. The fundamental nature of this relationship is therefore one of power and balance. Patients are vulnerable and in need. We are powerful and in control. The most basic element of professionalism is that we recognize and respect the nature of this relationship, and that we treat all of our patients with compassion and empathy, at all times putting the needs of our patients, both physical and emotional, as our top priority. It is important to note, however, that the individual relationship between doctor and patient is just as important in today's high-tech healthcare environment as it was hundreds of years ago. Take a moment to consider the following. Compassion and empathy are important professional behaviors for all doctors. Have you ever missed an opportunity to demonstrate empathy to a patient, perhaps because you were too tired or rushed or are overworked.
The next module video deals with disruptive behavior, a theme that I will be coming back to again in my second talk today.
As doctors, we have a duty to promote a positive working environment that enhances the performance of our team and results in good outcomes for our patients. Rudeness, harassment, or bullying should not be tolerated in any form in the healthcare setting. We have a duty not only to ensure our own behavior is exemplary in this area, but we have to defend our colleagues from this kind of behavior if inflicted by others. Bystander intervention is just as important as not engaging in this kind of behavior ourselves. Isolated incidents where a staff member or student is demeaned, intimidated, or humiliated are known as harassment. This includes advances of a sexual nature. Repeated incidents such as these form a pattern of bullying. Unfortunately, there is abundant evidence that bullying is not uncommon in healthcare teams. Bullying often occurs down a power gradient within a profession or discipline, but we must also be aware of interprofessional bullying, which may occur regardless of grade or seniority. Just as we would not treat our patients differently based on race, gender, nationality, or sexual orientation, we must not discriminate against colleagues, juniors, or other staff members on these grounds either. Discrimination can also occur without gender or cultural factors. For example, where one individual is given preferential treatment or training advantages over another. Take a moment to consider the following. Most of us would feel that we do not harass or bully other members of staff. But how many of us could say that we have never seen this occur between others? Did you intervene the last time you saw this occur?
On completion of the module video, participants enter the learning resource area, which contains the study material for that module. The study material consists of a selection of published scientific papers and also videos which are relevant to the subject matter of that module. The papers have been handpicked by our team for their relevance and for the prestige of the authors. Here are two examples. Firstly, there's a paper by Lucian Leap dealing with the culture of respect and the nature and causes of disrespectful behavior by physicians. And here is another paper by a group of highly regarded American surgeons dealing with behavioral problems in surgical residence. The learning material usually also contains freely available videos which have been chosen by our team for their relevance and importance. I'm now going to show you an example of one of these videos. This is a short video which was produced by the Cleveland Clinic in the United States, which deals with the area of empathy. This is a really powerful video. It's just 4 minutes long, but it's particularly powerful because during those 4 minutes, not one single word is spoken. Everyone has a story. Every patient we treat, every colleague we work with, they all have a story in their lives. Empathy is about our ability to tap into those stories and to actually feel what other people feel. Empathy is a key ingredient of professionalism. On completion of the reading and viewing tasks in the learning resource area, participants can then take the multiple choice question or MCQ test. For each of the 12 modules, there are 50 multiple choice questions. These are simple true-false questions which are designed to verify that participants have completed the reading and viewing in the learning resource area. They're based entirely on the content of the learning resource area. If the participant passes the MCQ test, they can then go and download their CPD certificate, and they can print off the certificate for their professional competence scheme. What we have tried to do is design an online course on professionalism, which is based on an academic syllabus and which can earn valuable CPD points. It has been designed for access on any mobile device, but particularly on the smartphone, so that participants can access this course at any time and anywhere. It's relevant to medical doctors of all specialties, not just surgery. Right now, this course is only available in Ireland, but we are hoping to make it available to doctors around the world over the next few months. We hope that this online course will address some of the challenges of teaching professional values, attitudes, and behaviors to our doctors of tomorrow. Thank you.
Thank you, Dr. Traynor, for your talk. I would like to thank you for giving this very valuable information about your online course. We hope it will be available for everybody, even outside Ireland soon, so that we can also get a chance to see that. So far, I don't see any questions from the audience. If you have any questions, please do write on the chat screen. Olan varsa yazarak bildirebilir. Şu ana kadar bir soru almadım. There is one question, Dr. Traynor, asking, is it free or do they have to pay anything for that course?
The course is free for all doctors in Ireland, and it is my hope that it will be free when it is made available internationally also.
And how many doctors have already taken this course so far?
There are about 600 or 700 have taken it so far in Ireland, but it's still at a very early stage.
Is it intended for postgraduate only, or is it available to undergraduates as well?
I think it would also be very valuable for undergraduates because I think the principles of professionalism are principles that should be learned as early as possible in our medical careers. So we are making it available right now to the undergraduate medical schools in Ireland also. There are 6 medical schools in Ireland, so we're making it available to them.
It is the same course, there is no difference, and both undergraduates and postgraduates can take the course, even the students can take it.
It's exactly the same course, because I guess if you think about it, the principles of professionalism are the same, and they're the same not only at undergraduate and postgraduate, they're also the same for all specialties, and they're also the same for every country in the world. The really amazing thing is that the principles that were laid down by Hippocrates 2,500 years ago have not changed very much, despite all the advances that we have in medicine. The principles of professionalism are still pretty much the same as they were thousands of years ago.
There is a question, is there a follow-up about the impact of the course on the professional activities of the doctors? Did you have a follow-up, or did you follow those patients, those doctors who have taken the course versus the others who did not have it? Did you have a study?
To be honest with you, no is the answer. We have not, because the course is still very new. So it is probably too early to see the impact. But it is something that we will be looking at.
When did you start the course? When was the first time that you gave it?
We launched the course originally just about 2 years ago on a pilot basis, but just launched it for all the doctors in Ireland about 10 months ago. So it's still very, very recent.
So is the financial support provided by the Royal College of Surgeons?
No, the financial support was provided by the Irish government, by the Department of Health in the Irish government.
There is a question, I think you have answered that, but I have to ask this. What is your definition for professionalism? Your description echoes humanistic approach, it writes. What would you say about this?
Yeah, I think like there is a lot of talk at the moment about professionalism. It's a very topical area, and lots of different groups have tried to come up with a new definition of professionalism. But to my mind, the best definition that I have seen for professionalism is the values, attitudes, and behaviors that underpin our practice as doctors.
Another question, do medical students and or nursing students have training about professionalism during their study in their faculties, during their curriculum?
So I think, sorry, I'm not sure I heard the question correctly, but I think your question was, do nurses have access to this?
Students and nurses, nursing students, do they have training about professionalism during their studies? Is there something specific about professionalism in the curriculum?
They do, but to be honest, this course is aimed specifically at doctors. So it's the principles of professionalism for doctors. So even though we are all part of a multidisciplinary team now, the principles of professionalism in this course are specifically based on the principles of professionalism for medical doctors.
Another comment is that role modeling is very important to achieve values, behaviors, as Dr. Traynor stated. However, I have some considerations about the effectiveness of the online course to taking role model. How can we ensure that, or how we support our students with mixed methods?
Yeah, I absolutely agree on that point. There is no good substitute for role models. The traditional apprenticeship model that we all grew up with is really the best model for inculcating these professional values. But the reality is that that model is not working as well as it did 20 or 30 years ago, because there is pressure all around the world. There's pressure to shorten postgraduate training programs, to make them more streamlined. And also in many countries, there are restrictions on the number of hours that trainees can work in each week. I'm not sure what the situation is in Turkey, but in Europe, there is a 48-hour maximum working week. So that makes things very, very difficult for people to have the same exposure to role models as they did in the past. So definitely it's not as good as the traditional role model effect, but it is an attempt to try to substitute, to try and to make up for the lack of role modeling that exists today.
If not substitute, maybe complement the role modeling?
Yes. Yeah.
But it will complement that in a way more structured. And is it, are those modules obligatory for all postgraduates, or is it on a voluntary basis?
It's all on a voluntary basis. So it is a mechanism for people to fulfill the requirements of their continuing professional development. But it is all on a voluntary basis at the present time.
Another question is saying, would you recommend to retake this course or modify the version after a while, for example, 5 or 10 years later?
Oh, absolutely, yes. Once you sign up for the course, you can do it as many times as you like. And the good thing about the course, because it's available on their smartphone, you can do it at any time that suits you. You could do 5 minutes and then not come back to it again for 3 weeks if that's what you want to do. Or you could do 2 hours and do another 2 hours next week. It's entirely flexible. You can take the modules in any order that you prefer. You don't have to go in any fixed order. So you can use it anytime, any place, and in any order that you wish to take it.
And it will be developed in time, I'm sure. It will be, some modules maybe will probably be changed or developed
Yes.
as requirements.
Yes, absolutely. You know, although the principles of professionalism have not changed very much for hundreds or even thousands of years, there are certain details that are changing. For example, the whole ethics around social media, the use of social media in medicine, obviously that's a very new area. But there are other areas like honesty and integrity that really have not changed for many, many years.
Yes. I think we don't have any more questions at this point. So you can proceed with your second talk, which is disrespectful behavior in the clinical environment.
Okay, so can you see that PowerPoint?
Not yet.
Oh, okay. Maybe I'm not sharing the screen. Hold on.
Now it is
Can
okay.
you see my? Okay. Okay, you can see that?
Yes, yes.
Okay.
Perfect.
So my second talk today deals with the very important topic of disrespectful behavior, and particularly the impact that disrespectful behavior has on people, on the clinical environment, and ultimately on patient safety. As healthcare professionals, we all work in an environment that is becoming increasingly complex. Robotic surgery, advanced diagnostic imaging, and artificial intelligence are just some examples of how technology is changing the way that we deliver care for our patients. But it's not just the technology which is becoming more complex. The people involved in the delivery of healthcare are also changing, and increasingly they're coming from more diverse and varied professional backgrounds. The traditional healthcare team consisted largely of doctors and nurses. The healthcare team of today is a much wider multidisciplinary team and multi-professional team. Every member of this multidisciplinary team has an important contribution to make to patient care. And it is our duty as doctors to ensure that all members of the team work harmoniously in the best interest of our patients. The patients that we treat are also changing. Today, we deal with patients with much more complex problems. Patients who have multiple comorbidities. Patients who are much older, much more frail, and often on multiple medications. We truly work in a complex environment. And at the heart of this complexity, relationships are more important than ever before. Relationships with colleagues, relationships with trainees and students, and relationships with our patients. A key element in our relationships with colleagues and with patients is the very important issue of respect. Respect means always treating others with dignity, recognizing and valuing their opinions, even if their opinions differ from our own. As doctors, we have a professional responsibility to manage the whole issue of respect in the clinical environment, and particularly to manage the important issue of disrespectful behavior. In this session, we will look at the nature and origins of disrespectful behavior, the effects and the impact of disrespectful behavior, and finally, we will look at some tips and tricks for dealing with disrespectful behavior in the clinical environment. There are a number of different types of disrespectful behavior, including disruptive behavior, humiliating or demeaning treatment of colleagues, passive-aggressive behavior, passive disrespect, dismissive treatment of patients, and systemic disrespect. Disruptive behavior, as its name implies, is behavior which disrupts or impairs the ability of the medical team to achieve its intended outcomes. This includes angry outbursts and tantrums, verbal threats, shouting and swearing, or even the use of physical force. Disruptive behavior has a pervasive, detrimental effect on the people in the healthcare environment. The victims can include medical colleagues, nurses, residents and trainees, students, ward staff, administrators, and patients and their families. Humiliating or demeaning treatment of colleagues is self-explanatory. Often, this type of behavior takes place in public, and it often happens down along a power gradient. By this, I mean that the victims of this behavior are at a lower level in the hierarchy of healthcare and are therefore in a weak position to respond. For nurses, this is a significant cause of burnout and a significant factor in attrition. Medical students and trainees, on the other hand, often tolerate this behavior because of concerns that speaking up might harm their career progression. Passive-aggressive behavior is a very challenging problem. These are people who are unable to express anger in a healthy way, and so they disguise their true feelings in order to make people think that they are normal and that they're a nice guy. People who are passive-aggressive have an internal anger, are critical of authority, have negative attitudes, they often blame others, and they either refuse to undertake tasks or they do things in a way that's designed to annoy other people. Passive disrespect is common. It consists of a range of uncooperative behaviors that are not malevolent or rooted in suppressed anger. Whether because of apathy, burnout, situational frustration, or other reasons, passively disrespectful individuals are repeatedly late to meetings, respond sluggishly to calls, fail to dictate charts or operating notes in a timely fashion, and they do not work collaboratively or cooperatively with others. They often resist following safe practices such as hand hygiene, checklists, or timeouts, even when the rationale has been sufficiently described. Dismissive treatment can be experienced by patients, but it can also be experienced by nurses, students, trainees, and other healthcare workers. In the case of patients, not only does such behavior violate the fundamental obligation of the physician to provide support and healing, but it can be devastating for the already apprehensive patient. Many features of our healthcare system are so firmly entrenched that they are taken for granted and not recognized for the disrespect that they represent. Examples of this systemic disrespect include expecting patients to wait unnecessarily, depriving them of privacy or dignity, and simply failing to communicate adequately with them. I'm now going to show a short video that illustrates the problem of disruptive behavior. This video was made by the Royal Australasian College of Surgeons as part of their Operating with Respect program. The scene is based in an operating theatre, and the scenario concerns a surgeon and his trainee. But what happens in this scene could happen anywhere. The operating list is already quite full, but an emergency case has been added by the trainee and the surgeon is not happy. The sound is a little low in the beginning, but it picks up after a couple of minutes, so just be patient with it.
My name's Amal. I'm with the surgical team that's going into the theatre with you today. Just wanted to confirm some things and do a pre-op check if that's okay. Can I confirm your first name, please?
Chris.
Chris. And your date of birth, Chris?
The 28th of the 10th, 91.
And can you confirm for me the side of your injury?
It's the right side.
And when was the last time you took anything orally?
Last night.
Sure.
Look, Olivia, if you're going to add acutes onto the elective list, you're going to have to tell me about it sooner.
Yeah, I'm really sorry. I thought they were going to be done in the emergency theatre, but then ours finished early and the emergency theatre's still got a big orthopedic case. And I thought the charge nurse might have talked to you about it, but I should have. I'm sorry.
No one's told me anything about it. So what did you think was going on when you examined the patient?
Well, Tom admitted her overnight. She had a fall from the mountain bike yesterday evening and sustained, a few superficial grazes and then a more significant injury to her groin. And he showed me the photograph, and it didn't look too bad. But
So you haven't actually examined the patient?
no, I should have. I was just a bit busy. I'm really sorry.
It's unacceptable. We can't operate on somebody if we haven't examined it beforehand. I guess she's asleep already, but it's not how you do it.
Yeah, I'm really sorry.
Tell me about the femoral triangle, Olivia.
So femoral triangle is bounded superiorly by the inguinal ligament, laterally by sartorius, and medially by adductor magnus.
Okay, and what about the contents?
Femoral nerve, artery, and vein, and some fat.
Pretty scratchy.
Yeah.
Have we done one of these cases before?
And not on this run. but I did do a lot of varicose veins last term.
Okay, why don't you get started? I'll be scrubbed in and we'll see how we get on.
Okay, thanks.
Who are you?
I'm Mr. Denny's. I'm just the intern. I'm Mark. Just wondering if I could observe you today.
You're on our run, aren't you?
Yeah.
Seen you either much. Have you scrubbed in before?
Just once during my last surgical run.
Well, when Mark is ready, can you give him a hand for scrubbing?
Yeah.
Stuff?
Sure.
Okay, cool.
You've done this before? I've only scrubbed once. Okay.
Okay, so we've debrided the wounds, we've enlarged it a little bit. Let's see how we go. All right, just buzz through. Yep, okay. Just quietly, just gently, there's no rush. Okay, find the saphenous vein, and we need those tributaries.
Yeah.
Yeah, okay, come on.
Here?
Just like that.
Okay.
Just bottom end, find the bottom end. Okay, so you're happy that's the one saphenous?
Yeah, I think so.
Yeah, all right. Okay, so just slowly now, just come up to the top. Okay. See the tributaries? There you go. Okay, that's going to duck down into the cribriform fossa. So just fine.
Okay.
Yeah, just buzz through it. Give it a good burn.
Okay.
Okay.
Is that enough?
It's not quite clear, is it?
No.
Look, there's a bit more blood here than I would have expected. Give us a self-retainer. No, the decent size one. Come on. Just give us it, would you? Just need a bit more access. Okay. Next, Langenbeck. Yep, that's right. Okay. I'll hold on to that. Just keep going. Keep going.
I can't really see where to go.
Look, just follow the long saphenous now. We want to see that junction with the femoral vein. Look, actually, just give us a suction. Suction. We're going to need to see a bit more here. Suction on. Turn it on, would you? Turn the suction on. Come on. Quickly now. Okay. Stop. Actually, that's not right. That's not right. There's more of a problem here than I thought. Looks like we get. This is what I was on about before about the possibility of a vascular injury. You know, but you just can't. You can't let this happen. It's unacceptable. Look, just push on this for a bit. I'm going to have to take over. We've got a significant problem with the vein. Just push on it, would you? Okay. I'm going to take over. Stay there. You can't screw that up. This is going to screw like that. Okay, ready to go. Is everything all right? Look, we've got a bad problem. I don't know what it is yet, but it looks like we've got a significant problem with the vein here. I can't quite tell yet. Give us that Langenbeck. Mark, come in here. Hang on to the suction. Make sure it's going. Just give it a proper look. We're going to need some blood. Get the suction going. Need some bumps? Now, come on, fluid. Yeah, we're going to need some blood, Gary. You know Alice is next door. She's finishing off the rod. We're going to need some blood. Suck on that. Give us a pack now. There's a major vascular injury here, Gary. Yeah. This is a problem. You're going to have to stop there just for one moment. I don't have a cross match. What do you mean? What? I've got a grip hold. I'll need to do one. No. I can't believe that you haven't done that. You know, this is what I was going on about. This is the problem with you, Doc. You're hopeless. Completely useless. You haven't seen the patient. You haven't marked the patient. You haven't consented the patient. You want to be a student? This is medical student stuff. This is completely hopeless. You are useless.
Robert.
What?
Looks like you need a hand. I'll go and get scrubbed.
Good. Yeah, look, come on. Let's just get on with it.
Although this was set in an operating theatre, I'm sure you'll appreciate that this could be in any part of the hospital and with doctors from any specialty. I'm sure you'll also agree that this type of behaviour is simply not appropriate, but unfortunately, it is all too common. This surgeon illustrated a number of different types of disrespectful behaviour, but behind it all, he had this passive-aggressive behaviour, where he had this really deep pent-up anger because an additional case had been added onto his list, and he was not happy that a case had been added onto his list. When disrespectful behaviour occurs, it has widespread detrimental effects. Clearly, it has an emotional impact on the victim, as was clearly seen in this video. But what often happens is that the perpetrator of disrespectful behaviour is often avoided by more junior staff so that they too do not become a victim. Such behaviour results in low morale and burnout, which in turn translates into high attrition rates among staff, impaired teamwork, and an increased risk of litigation. In my first talk earlier, I spoke about the importance of role modelling and the hidden curriculum in medicine. It's important to note that this type of disrespectful behaviour gives inappropriate role modelling messages, and this has consequences for future generations of doctors. But the net effect of disrespectful behaviour in the clinical environment is that it impacts adversely on patient safety and quality of care. Ultimately, this is why disrespectful behaviour is an important issue and why we need to address the problem robustly. We are now going to look at another short video which examines the aftermath of the events in the first video. In this segment, we will see the perspectives of the various participants in the previous scenario. As we can see, the fallout from the surgeon's behaviour has had a widespread impact, not just on the trainee involved, but also on the many other bystanders in the operating theatre.
This place is going from bad to worse. I can't keep working here. They don't know what they're doing. They just keep on piling on the work. They haven't seen the patient. They've not got the equipment. Nothing's been done, and they expect me to solve these problems. I can't keep on putting up with this.
Poor Olivia. I always wanted to be a surgeon. I know it's demanding. I'm sure I can cope with being treated like that. I wanted to speak up, and then it happened so quickly. I just wanted to get out.
I was appalled at what happened this morning. It was the behaviour of a 2-year-old. It's not the first time Robert's treated Olivia like this. I can manage him, but I wouldn't expect my staff to. The patient got lost in the middle of all this.
As time's gone on, Robert's gotten worse. I'm a bit worried about him.
He doesn't seem to be coping well under pressure. Maybe I should catch up with him and see if he's okay. But I'm just not sure how to take it. I'm thinking twice about taking on that private list he's been talking about.
That was just wrong on so many levels. Behavior like that is just not helpful. I didn't feel able to help. I was going to get caught in the crossfire. And he undermined her yesterday. I can't believe what he said to her in the tea room. That was so humiliating. I felt really uncomfortable. But I was too scared to say anything.
I'm going to have to deal with this. I can't let him treat people like this. How on earth am I going to bring it up? Don't want to go to the head of department. How can I do it low key? Maybe best to catch him in clinic sooner rather than later. Might be a good idea to chat to Sam and just think this through. I hope this isn't going to affect my assessment. I don't think it was entirely my fault. I mean, I missed a few things. You didn't have to yell at me like that in front of everyone. I just wanted the earth to open up. I couldn't think straight when he started shouting at me.
what is really disturbing in this last video is that everyone in the room felt uncomfortable with what had happened, and yet nobody felt that they could speak up or intervene. For the trainee herself, she did what many victims do, victims of abuse. She started blaming herself and saying, well, she didn't think it was entirely her fault, but clearly she was blaming herself for the behavior that happened. It's clear that this pattern of disrespectful behavior cannot remain unchallenged. But what can we do, and what should we do in such a situation? We now recognize that an important element of high reliability organizations around the world is the creation of a culture of safety. This is not a nebulous concept, but rather is something which is firmly enshrined in an organization's code of conduct. Every hospital and every healthcare organization should have a clearly defined code of conduct. This should not be developed by the hospital management and simply distributed to staff. Instead, it should be developed in close collaboration with all staff members and with involvement of the medical board of the hospital. The code of conduct should be explicit and should avoid vague aspirations. Expected behaviors, and more particularly unacceptable behaviors, should be clearly defined and spelled out. The code should be disseminated widely to all staff members and should be easily available on the hospital intranet. Introduction to the Code of Conduct should be an integral part of induction for all new staff members, and new staff members should be formally signed up to the Code of Conduct on commencing employment. There should be a clear pathway for reporting deviations from the Code of Conduct, with appropriate protection for those who report. Finally, the code should be reviewed regularly so that it does not become outdated and irrelevant. As a minimum, the hospital code of conduct should specify that we treat others with respect, courtesy, and dignity, that we communicate openly and with respect, that we encourage and support a culture of advocacy and openness, that we resolve conflicts in a non-threatening and discreet manner, that we provide clinical care with competence according to ethical standards, that we report any individual who may be impaired, that we report adverse events or safety risks, that we participate constructively in adverse event or incident reviews, that we maintain confidentiality for patients, families, and colleagues, that we uphold institutional policies, guidelines, and procedures, that we participate in professional development and training, and that we are at all times fit for duty, including when we're on call from home at night. The Code of Conduct clearly defines the acceptable and unacceptable behaviors in a healthcare organization. So what should any organization or any individual do when there are breaches of the Code of Conduct? There are 5 basic principles which should underpin the response to disrespectful behavior. The process must be fair and it must be consistent. This means that all staff members are treated equally. The most senior staff are treated in exactly the same way as the most junior staff for episodes of disrespectful behavior. But there must also be a proportionate response. By this, I mean that many cases of disrespectful behavior can be successfully managed without going to a full disciplinary procedure. I will come back to this in a moment. There should be a process for remediation, And there should be surveillance mechanisms to detect any early signs of recurrence of previous behavior patterns. What I would like to talk about now is the proportionate response, which can sometimes achieve effective results without the need for a full disciplinary process and all its consequences. I would like to recommend you to a very effective process which has been designed again by the Royal Australasian College of Surgeons last year as part of their Operating with Respect programme. It is called RACS Speak Up. This is an app which is freely available for download on the App Store and which gives excellent guidance on how to deal with disrespectful behaviour and how to manage a concept that the Australasian College has developed called a cup of coffee conversation. This is intended to be an informal conversation between someone who has engaged in disrespectful behaviour and a colleague. The cup of coffee conversation is adapted from the Vanderbilt approach to addressing unacceptable behaviour among healthcare workers. The Vanderbilt, of course, is based in Nashville, Tennessee, in the United States. The purpose of a cup of coffee conversation is to raise awareness, prompt reflection on the behaviour, and reinforce expectations. It is designed to be an informal response or intervention, which is intended to be a respectful conversation between two colleagues. It can be very effective when conducted early and assists in preventing the behaviour from escalating. The evidence suggests that a properly conducted cup of coffee conversation will produce the desired effect in more than 75% of cases, even when this is not immediately apparent at the time of the conversation. In this next video, we will see the same surgeon meeting with his surgical colleague who came into the operating theatre towards the end of that case in the first video. Here she meets him for, She meets him for a cup of coffee conversation to discuss what happened in the theatre that day.
Letter to the GP, last patient for today. Alice.
You got a minute?
Come on in.
I brought you a coffee.
You're a star, thank you. Look, I can have one of these all day. It's been that kind of day, actually. It's timely that you're here. I was going to say thanks for helping me out yesterday. We were in a spot of bother.
Yeah, that's what I've come to talk to you about, because I was a bit concerned when I walked into theatre yesterday, how rattled everyone was.
It was a circus. You know what it's like. You're new registrar. They don't know the patients. You don't know who you're getting. You've got a planned list. You get add-ons. You think you're going to finish on time. It's going to run over.
What I saw when I walked in was that you were really stressed and you were giving that registrar an awfully hard time.
I was teaching her. If someone's not performing, I'm always going to give them feedback. You know yourself, you've got to have a tough skin, Alice. I mean, you're just not going to survive unless you're tough enough in this game.
Robert, feedback is really important, but it's about how you do it and where you do it.
It's a stressful situation, our job. We'd all respond like that.
Well, I think different people respond differently in different circumstances. And if the team is stressed, then the performance suffers and the patient is put at risk.
What are you saying, Alice? Are you saying that I'm difficult to work with? I've seen lots of our colleagues behave far worse than that in similar situations. No one's ever told me they've got a problem with my behaviour.
Do you think there might be a reason for that?
So the Speak Up app gives really useful guidance on how to conduct an effective cup of coffee conversation, outlining all the principles and steps. It also gives very useful guidance on the management of what they call pushback. Now, pushback is very frequent and understandable occurrence during a cup of coffee conversation and results from the perpetrator being unwilling to initially accept that there is a problem. And we saw that very clearly in that last video where he said, are you saying I'm difficult to work with? Pushback comes in several different forms, such as avoidance, apologetic, denial, justification, passive-aggressive response, discounting, or even aggression. So here we see an example of justification, where the person invokes a sound or noble cause to justify the behavior. An example of this might be, I have higher standards than everyone else, and I sometimes get frustrated when others do not want the same high standards for their patients as I do. And we saw it in that video where he said, well, I was giving feedback, I was teaching her. This ignores the fact that there is no circumstance to warrant unacceptable behavior. And the app gives guidance on how to manage this situation. In the final video clip, we see the surgeon reflecting on the events of the day. And reflecting on the cup of coffee conversation and trying to process all that has happened.
That wasn't easy, but I'm so glad I did it. I hope he takes some of that feedback on. If it keeps happening, I'll definitely need to escalate it. I'm so glad I went through it with Sam first.
What a day. I'm shattered. No one's ever spoken to me like that before. Alice was pretty on to me after that clinic. She was sort of saying that I was the problem. I'm not sure I am, but well, no one's ever spoken to me like that before. Well, I know her well, so it must have been pretty tough. I'm not sure what to make of it all. Gary might know what to make of it, because he knows what I'm like. He'll be able to tell me if other people think like this too, I guess.
In a small percentage of cases, there will need to be escalation to a formal disciplinary process. And it is important that this happens if the preliminary attempts to deal with the problem on an informal basis are not successful. These issues should not be ignored or tolerated. It is an unfortunate fact of life that disrespectful behavior is not rare in the clinical environment. However, respect is a core element of professionalism, and we all have a responsibility to ensure that we treat our colleagues, our students, and our patients in a respectful way, and that we adopt a zero-tolerance approach to disrespectful behavior. Thank you.
Thank you, Dr. Traynor. Can you please open your camera? Yeah. Thank you very much for your second talk as well. It was very nice, very informative, and we have another application that can be used. Is it also free for everybody, and or is it available for the Irish doctors only?
Sorry, I missed that question.
Is it available in Ireland only, or is it widely available?
So the app that I showed you, the Speak Up app, yes, was developed not in Ireland, but in Australia. It was developed by the Royal Australasian College of Surgeons, but the app is freely available on the App Store. It costs nothing, it's free, and anyone can download it. It contains a lot of very useful information and a lot of tips for dealing with this situation. I would strongly recommend this app to everybody who has to deal with colleagues who are sometimes difficult to deal with. It has a lot of very useful information.
We have a question from Professor Sayek, mostly related to the first talk. He's asking, is there a relationship between professionalism and social accountability? What do you think about it?
Is there a relationship between professionalism and social accountability?
Yes.
Yes, I think absolutely there is. I think one of the core elements of professionalism is our implicit contract with society. As a profession, medical doctors, as a profession, we have an unwritten implicit contract with society. And that is what underpins our profession. That's what actually makes us a profession and differentiates us from carpenters or jewelers or any other trade or occupation. What actually underpins us and makes us a profession is this implicit contract with society.
Yeah, there are some comments from the audience. One is commenting that whenever she sees anybody who tends to behave disrespectfully, she feels pity for them, and she thinks that they need help to learn how to react and behave. Most of the time, they only need help, as far as I have observed. That's the comment. What would you?
And I think that is exactly right. And that's what we saw in the second video there, where we were looking at the perspectives of the onlookers, the witnesses who were in the operating theatre. Every single one of them felt that this was wrong, that it should not happen, that it was humiliating for the trainee. And yet not one single one of them, not even the anaesthetist who was a colleague of the surgeon, none of them felt empowered to speak up and do anything about it. So I personally think that we all, as a profession, we all need training in how to deal with disrespectful behavior. But absolutely, we should not and must not do what we have done for generations, which is ignore it and pretend that it's not happening. We all need to speak up.
Another colleague is stating that she thinks that professionalism as a value has many difficulties, socially, culturally, politically, and educationally. And because professionalism is created as a product of these aspects, struggling against those angle-induced difficulties is not only medical educators, clinicians, and medical schools' responsibility, but also health managers, lawmakers, and society's responsibility. And is asking, what do you think about whether there is a need of planning and organizing a multifaceted professionalism education with multiple stakeholders, not only medical doctors or medical professionals?
Yeah, and I absolutely 100% agree with that. In our country, in Ireland, since 2007, the Medical Council is the regulator of the medical profession in Ireland. I guess you probably have something similar in Turkey, but I'm not sure how it's structured. But in Ireland, since 2007, the Medical Council must have a majority of lay members. So there are 25 members of the Medical Council, and 13 must be lay members and 12 doctors. So the majority, it's a small majority, but nevertheless, it's the majority must be lay members, and they are drawn from all sections of society. They're appointed by the government, but they're drawn from a wide spectrum of stakeholders in society. And I think that's good. When it was first introduced in 2007, the medical profession were very opposed to it, because prior to that, the Medical Council was composed of almost exclusively of doctors. But since 2007, there was a majority of non-medical people on the medical council. And, you know, even though the medical profession were a little uncomfortable in the beginning, I think everybody now appreciates that that is the correct way to have it.
Another comment is saying, while medical ethics constitute an important field of medical school programs, the educational environment and ethics, in other words, instructional ethics, are unfortunately ignored. Respectful behavior should be widened for the all education environment in medical education, and relevant codes should be determined, which you have also pointed out in your talk, the medical code of behavior. What would you do? You want to tell anything more about this aspect?
Yes, no, I agree 100%. I think that we really need to put much more emphasis on teaching these behaviors at undergraduate medical school and also in postgraduate training programs. But it should start in medical school. And we should not rely completely on role models and role modeling, because for the reasons that I outlined, that's not working as well as it did in years gone by. So I think we really need to focus on teaching these behaviors, these values, these attitudes to our medical students from the very beginning of their medical school course.
Thank you. Another comment, which is also shown in the videos, she thinks that moral injury harms not only the victim, but also the bystanders, which we have observed in the video that you have shown us.
Yeah, no, absolutely. And we could see in those videos the impact that the whole event had on the other people, even though they were not directly the victims. They were impacted by it as well. They were emotionally upset by what happened. And they all knew that this was wrong, that it should not happen, and yet they felt powerless to intervene and do anything about it.
We have another comment. It says, the concepts of respect, disrespect, offensive behavior, and abuse are very clearly outlined in such examples like the video that you showed us. But the differences between harm and good intention will not going to be crystal clear as it was in the video at the time. Don't you think cause of conduct may empower people who falsely claim to be abused or simply couldn't understand the good intentions of the lecturer because of the intrinsic problems?
I'm not sure I understand the question there. That question relates to understanding the code of conduct, is that?
Yes.
Well, I think that every hospital, every healthcare organization needs to have a formal induction program for new staff, and training in the code of conduct needs to be part of that. I think that very often a code of conduct in a hospital is something that's put away in a drawer or a cupboard somewhere and gathers dust, and nobody really looks at it except the managers. I think that it needs to be part of everyday life in the hospital. And the way to do that, the way to get everybody buying into it, is to have everybody involved in drawing up the code of conduct. You know, the best regulator of behavior is society itself. We often think that police are the people who impose the rules and the regulations of our civilization, that police officers impose them. But in fact, the best regulator of behavior in society is society itself. If we rely on police to come and impose the law, it will not be as effective. It'll be more effective if all of society buys into it. And that works best if society are part of drawing up that process.
All right. We don't have any other questions as far as I can see. Yeah, we have one more comment. It goes, some topics, including values and respect, are challenging to teach with the course books and do not, but we can explicitly show with our behavior and actions. At least, can we reach some people and they will highly likely to have an effect on other people, which I think emphasizes the importance of role modeling. So we cannot teach everything by course books and so on. So we should approach some people. So role modeling should be the best way of teaching behaviors. I think that's what it is meant in the
Yeah, and essentially I agree with that. I think role modeling is the ideal way, but if it's not possible today to use role modeling as much as it was in the past, then we have to find other ways of teaching. And to be honest, I do not think that didactic teaching in a lecture theatre will have much impact. I think that the type of teaching needs to be based on showing examples like those videos that I showed, where you show examples of good behavior, bad behavior, and then ask the students to comment and dissect out what's good and what's bad. And I think by showing these examples, that will work better than just doing didactic teaching with slides on a PowerPoint presentation. You cannot teach behaviors in a lecture theatre.
Perhaps another way can be while having bedside teaching, spending some of the time, part of the time for these topics, like ethical and code of conduct, behavioral aspects, should be part of the bedside teaching as well.
Yes, absolutely. It needs to be explicit. In the past with role modeling, it wasn't explicit. The trainees learned by watching their senior colleagues, and they then copied their behaviors, copied their values. So it needs to be a bit more explicit, where it's actually spelled out.
Yeah, not necessarily dedicated sessions, but part of the sessions can be spent for those topics.
Yeah.
I think we don't have any more questions and comments. Thank you very much, Dr. Traynor, for being with us. It was very useful, very profitable for all of us. And thank you for all the colleagues who attended the session and made this a very lively and as much as possible interactive session. Thank you all. Thank you, everyone. Thank you.
Thank you for inviting me, and I hope the next time I can actually be present in Istanbul. Thank you.
We hope so, Dr. Traynor. Thank you very much Sabri Hocam, and thank you very much Dr. Traynor. Sevgili arkadaşlar, herkese katkıları ve katılımları için çok teşekkür ediyoruz. Saat 3'te lütfen programdan yeni section'a, oturuma katıl yerinden basıp gelebilirsiniz. Bir panelimiz var. Eğitimin yönetimi, pandemi ve eğitimde değişim. Şimdi size çay ve kahve molası veriyoruz. Saat 3'te bir arada olacağız. Çaylar benden ama nasıl olacak bilmiyorum. Hepinize çok teşekkürler. Sağ olun. Dr. Traynor, I personally thank you very much for your contributions and for your nice talks, and hope to see you in Istanbul in a very healthy days. Thank you very much. Bye for now. Thank you. So we are ending this session.
Teşekkürler.
Çok teşekkürler hocam, size de sağ olun. Arif hocam, bütün şeyi kapatabiliriz.
Hocam teşekkürler. Oldukça akıcı bir toplantı oldu. Sabri hocam, ağzınıza sağlık. Hala katılımcılarımız var. Onlara da katılımlar için teşekkür ediyorum ve izninizle toplantıyı sonlandırıyorum.
Çok teşekkürler, sağ olun.
Hocam Discord istersen iptal et. Discord sonlandır.
O kapatınca söndürüyor zaten.
Peki. Tamam hocam. Görüşmek üzere.
Teşekkürler. Görüşmek üzere.